So we shall now go on to our next speaker, Dr. Haripriya, who is the Chief of Intraocular Lens and Cataract Services at ARAVIND Eye Hospital, Chennai, and an amazingly prolific surgeon. And then she is going to definitely have a lot to tell us on capsular bag challenges. And on to you, Dr. Haripriya.
Thanks, Dr. Chitra. Are my slides visible?
Yeah.
Thank you. So I'll be talking on capsular bag complications. So in the postoperative period, I think the most common capsular bag complication one would encounter is posterior capsular opacification, and this could be related either to the technique per se. Obviously, we see less of this when we do a phacoemulsification and have the lens in the bag, and the IOL design as well. So in instances where we have a square edge lens, posterior edge, that would help to create a shrink wrap, and thus reduce the chance of lens epithelial cell migration and therefore PCO. So to an extent, the technique and the lens design could help, but where the patients do have a PCO in spite of it, the good news is it's easy to treat. The bigger problem would obviously be access to a facility which has these.
Could everybody please be mute themselves so that we can have an undisturbed talk?
So access is one challenge which can be there, especially if you're doing for patients in the periphery and the suburbs. The other aspect would be the capsular bag distension syndrome. The other complication could be capsular bag contraction and capsular bag IOL complex decentration or dislocation, which could either be because of pre-existing zonular weakness or because of compromise during the surgery of either the capsule or the zonal apparatus. So capsular bag distension syndrome is seen typically in patients who have received a capsular rhexis, and the rhexis covers the edge of the optic. Now, this is a very rare complication, probably seen more in high myopes with axial length more than 25 millimeters, and sometimes in patients who receive 4 haptic IOLs. Again, the good news is when the patients do come to us with defective vision, the good news is it's easy to diagnose and to treat. So doing a YAG capsulotomy, the patient has immediate relief, and more so over the next 2 or 3 days once the lens matter in the anterior vitreous gets absorbed. Capsular bag contraction is something which we would see, especially in patients who are more prone to it, like patients with retinitis pigmentosa or pseudoexfoliation or ectopia lentis. Also in patients who receive a smaller capsular rhexis, especially in patients with pseudoexfoliation where one tries to avoid making a large rhexis for fear of extension. So those patients also have a small rhexis, which again increases the chance of capsular bag contraction. And again, these patients, if identified earlier, it's easier to YAG the phimosis and release it. Interestingly, in patients with retinitis pigmentosa have a very high risk of anterior capsular contraction. And we also have seen complete capsular, anticapsular contraction in patients with RP, even at the first month follow-up. So again, it's important to remember to make a slightly larger rhexis. But if one does not do it, at least end of surgery before aspirating the viscoelastic, one can just take in the vanas and relax the rhexis margin so that you prevent the contraction forces, which would also reduce the chance of further zonular damage and IOL decentration. In these instances as well, a YAG could be done to release the phimosis. Moving on to patients with IOL decentration. So this is a patient again with pseudoexfoliation. A couple of years later, the patient comes with a capsular, with an IOL decentration with a Sommerings ring. And the capsular bag is also loose here. The IOL is not in the capsular bag, and there's a lot of lens matter here. So the first option obviously would be to try to refixate the same lens. In this case, because there was a lot of lens matter, I prefer to explant this IOL and place another IOL. So while doing it, 2 instruments could be used, 2 Sinskey hooks to dial the IOL capsular bag complex into the anterior chamber, grab the optic haptic junction. That way you'll ensure the haptic doesn't get stuck in the tunnel, and remove the lens with the capsular bag complex. So we can see the patient has pseudoexfoliation material on the pupil. So for a secondary IOL, which either technique, either a serial fixated iris claw, whichever the surgeon prefers, one can adopt. Here I'm doing an iris sutured lens, which is my primary choice of lens. So I'm using a 10-0 proline suture, using the same suture needle. I make 2 bites exactly opposite, each bite about 2 millimeters long, and retract the loop from below the iris, bring it out through the main tunnel, and have this looped at least twice over the leading haptic. So the right loop goes around the leading haptic. Now this is a large tunnel. So I've made this large because the primary IOL was a rigid lens, so I could not cut it. So I use a rigid lens here. And the trailing haptic also is looped with the same suture on the left side. And the IOL is placed in sulcus, which is which is now dangling with the help of the suture. So both the sutures in the anterior chamber, the end is then extruded, and then the knot is tied so that the IOL is thus stable. This other case, the IOL is well centered, but this patient has a toric lens and has a refractive surprise. So this patients need a IOL explantation, IOL exchange. Now, and a concern could be the additions. Now, this patient had surgery. If it's within 2 to 3 weeks maximum, the hydrophobic lenses are easy to remove. If it's beyond that, one will have to use viscoelastic, use a spatula, or use visco below the rexus margin, use 2 instruments and reduce the synechiae. So you have additions either between the anticapsule rim and the optic, or more dangerous if you have it between the haptic and the capsular bag equator. So here 2 instruments are used to bring the IOL into the anterior chamber. IOL is grabbed using a micro forceps, and then the IOL is cut into 2 halves. If one does not have the micro grabbers, one can consider holding on to the haptic. So the haptic, which is externalized, can be held tight, and this can also help bring the optic more anteriorly and stabilized. And then use your vernas or your micro scissors to cut the IOL into 2 and then explant the lens. So if one is planning an IOL repositioning or an IOL exchange, the hydrophobic lens, I think it's better to do it within 15 days. That is ideal, but even if it's after a month or 2, it's not bad. But anything beyond that, one may have to amputate the edge of the haptic adherent to the capsular bag to prevent any further zonular loss. Here the capsular bag is intact, so the new toric IOL then goes into the bag and placed on axis as per the plan. This other case again is a lens which is decentered here. The reason it is decentered, the patient had a PC rent, and the surgeon had planned to place it in the sulcus. However, the IOL was placed in the bag, and since it was an inferior capsular tear, the IOL is decentered and was decentered inferiorly. So here the option is to place it in the sulcus because there is adequate capsular support all around, and the haptics are also PMMA. The same lens can be used. So to ensure the haptic is stable on the capsule, the Coughlin's hook is used to retract the iris. One can also use iris hooks or use the Coughlin's hook to retract the iris and then dial to ensure the IOL is stable. So this is a patient who had a surgical complication, but because of improper placement during surgery, these lenses decenter. This other case again is decentered, again a patient with a PCR. So the first goal obviously is to try to center the same lens using the existing capsular support. However, the capsular support is not much. There is no PC support, and the anterior capsule rim is also less than 5 clock hours. So this is not going to center. So one, in this case, one may either choose to, refixate the same lens or exchange. Refixating is easier if the refractive outcome is good because then you don't have to have the extra manipulation maneuvering. So using a 10-0 proline suture needle, knowing where the haptic is placed, a suture bite is taken, including the haptic and the iris. Once this is done through this common side port, both the suture ends in the anterior chamber are retracted out through a modified mechanical suture. The knot is tied such that the haptic is now fixed to the posterior side of the iris. So I place about 6 to 7 knots here, and this helps to secure the haptics well. So this is a technique which is fairly easy to do. The only challenge would be it may seem like a blind procedure. So before I take the bite, I would retract the iris using a Coughlin's hook identify where the haptic would be and then take the bite. And while I take the bite, I look if the optic is also tilting, which ensures that the bite has also included the haptic while it is. So you can see the lens is also tilting, which means the suture needle has included the haptic while the bite is being taken. The second haptic is also secured in a similar fashion because there is only less than 5 to 6 clock hour anti-capsule support here. So instead of risking a decentration or tilting, both the haptics are fixated to the iris. So in conclusion, to reduce postoperative capsular bag complications and IOL decentrations because of a compromise in capsular bag, I think some things which we can do is to ensure the capsular excess is large enough, especially in eyes with weak zonules, to prevent capsular contraction. Again, if the patient does have a PC rent, ensure the IOL is placed in sulcus. A 3-piece design would be better, but if the support is inadequate, better in the primary surgery itself to fixate it to either the iris or the sclera. One can consider using a CTR or modified CTR if you're not sure about the capsular bag stability, either because of a preoperative or an intraoperative zonular lysis. In patients where we have higher risk of PCO, then it's also good to ensure we have an annual follow-up so we can treat the patient when the vision reduces. Thank you.
That was a wonderful talk, Haripriya, and so many videos with take-home points that most of my questions are answered, rather than for the attendees too. But if there is a case of a high myope and there is, PCO tends to be quite challenging in these cases. So what are the intra-op measures and what would be your post-op measure to deal preventing PCO, or as brief as?
Yeah, so I think one thing during surgery is to try to do, routinely also I do a wash of any residual lens epithelial cells, so any fibers you have. So I would like to wash that in myopes, again, in all cases as well, but more so in myopes because you want to either prevent or delay a PCO. That's the only modification I would think of. And a 3-piece lens is what we would do in high myopes, which is, again, many papers have shown that 3-piece IOLs have a better chance of delaying PCO than a single-piece design. Post-operatively, if the patient does present with a PCO, I would normally get a clearance from the VR colleague to look for any peripheral lesions which require any barrage or laser to be done before a YAG is to be done. So I would not take it directly for a YAG capsulotomy.
Would you look for a PVD and feel it safer to do a YAG in these patients?
That is true, yes. That's another factor which would also help us.
Dr. Suchi, I wanted to ask you, if it's a severe capsule phimosis with zonular weakness, how would you approach this case? Can we have an entire panel view, Mr. Sharik?
It's already there, ma'am.
Oh, sorry, it's not there for me. Okay, fine. Dr. Sufekci, I wanted to ask you, a severe capsular bag phimosis and there is zonular weakness also. What would you suggest? Would you say that we remove the entire bag, or you would have some novel way of doing things?
Okay, so I really think it's important to decide whether you want to preserve that lens. So if it's a multifocal lens and the fellow eye has already a multifocal lens and the patient says, can you please try to save my lens? Yeah. Then I've gone to the extent of hooking up the bag and then trying to dissect free the subcapsular fibrosis, by separating with toothed and non-toothed instruments to peel off the subcapsular fibrosis. And once you find the plane, actually, it's not that difficult to actually start to slowly tease away all that fibrotic tissue that's causing the phimosis. And if you really find it's really adherent, then you can just cut with scissors so that it does not rip out. And once you've done that, then I put in a CTR, and as necessary, I put in capsular tension segments to fixate with Gore-Tex sutures to the sclera. But if, that's just a monofocal lens and the patient doesn't mind having that change, then my preferred technique is to explant completely, do an adequate vitrectomy, and then do a Yamani fixation, because I think that gives a really secure anchoring of that lens. And it's really a very stable outcome.
Do you believe that in a high myope and a toric IOL, placing a CTR makes sense, or it is just a theoretical talk?
I do that. if I want to preserve a toric lens and a high myope, trying to avoid going into the vitreous, to do gel removal. So yes, I would try to avoid, those extra maneuvers to protect the retina. So I would try to preserve the lens and the lens bag then in such patients.
Dr. Haripriya told us a very good point that, if it's a RP case or an eye with severe pseudo-exfoliation, making those nicks on the anterior capsule during surgery would be one solution of sort. How many of us do that actually? Yes, Kamal?
I do that regularly. And in case I'm not going to do a nick sometimes in the rexes, because most of these pupils may not be very large, I make sure I put in a CTR in these situations, because that further delays the situation for me. But in case I have a big dilated pupil, I probably go in for a larger rexes. That also reduces the incidence. And I give three cuts at 90 degrees each. 3 cuts on the rexes, small little rexes, and it does the job.
Good. I think Ramurthy, you have anything to add? Oh, yes, Dr. Nath. Yes, Dr.
Whatever I said on the retinitis pigmentosa is correct, but even without the fibrosis of the anterior epithelial cells and capsule, they can have a late decentration, because RP patients, irrespective of the pool on the zonules because of the small pupil and phimosis, they can have a zonulopathy and have a late decentration with a decent rexis size and no evident phimosis. So RP patients are at a risk and they need a counseling, and this is the session of the counseling. So we need to tell this patients and follow that up for a long, long time.
Yes.
Okay.
Yes, Dr.
We actually did.
Yes, please go ahead.
Yes,
Yeah. So we actually did a study to compare 2 groups in patients with retinitis pigmentosa who received and did not receive a CTR to look at did that help reduce the risk of phimosis, and we found actually it did not. That was something which we also, the pseudoexfoliation study, which we are almost about to complete, which included patients without pre-op phacodonosis, without intraop zonal loss, and where we again randomized them to with and without CTR. We did not find a difference in terms of capsular phimosis or PCO being different. But anyway, I mean, if you're having any doubt, like most of these RP patients during surgery itself, you do find some zonular weakness. So in those cases, I think it makes sense. But prophylactically using a CTR, we found did not actually have a big role.
Yes, Dr. Ajay?
I just wanted to ask Haripriya, I think that's a wonderful technique that you fixed the lens in the iris, but I just have a concern. Excepting the sensor lens, almost all lenses, sensor has an anterior curved surface, I mean anterior curvature, but the margins, but about this, especially the Alcon Acrisoft and many other lenses, they could be rubbing in the long, because you have done quite a few cases. So what is your long-term,
so
is there any pigment dispersion?
So normally for sulcus fixation placement, I always prefer the sensor lens. I don't
No,
do
about these lenses that you relocate the lenses that are already there.
Yeah, so if it's a PMMA lens, it's a rounded anterior edge, so there is no issue. If it is a single piece lens, I don't do iris fixation. I only iris fixate a 3-piece. If it's a Alcon 3-piece lens which has been already placed, I would still go ahead and fixate, because we find that even if you're fixating, the optic doesn't actually go and touch your iris. So we don't see a higher incidence of CME or pigment. Of course, you can because of the manipulation, but it's not much higher than or what you would expect of other of an iris fixation technique. So it does sit a little more posteriorly, where you would not, where your sulcus placement lenses would normally be seated.
Yes.
Thank you.
Just a couple of tips for any youngsters who are listening in. One is this, whenever there's a greater tendency for capsular phimosis, or sometimes even if you ended up with a small rexis and you're not confident enough to enlarge it, nicking the margin of the rexis is a good idea. But please don't overinflate the bag once, or the anterior chamber once you have nicked the rexis, because that sometimes makes the rexis run around. So you have to leave the eye a little soft. And the second thing is, in case you have a capsular bag distension, then when you are talking about a capsulotomy, you don't have to really puncture the posterior capsule. Just nicking the rexis margin where it overlaps onto the optics of the lens. That itself might suffice to leave the capsular distension and the lens might settle down.
Yes. Yes, Dr. Sandeep, before we go on to our next
Yeah,
speaker.
just one final thing which I found useful. Suppose I've done a case and it's a high-risk case for capsular contracture. One other thing that you can do besides nicking the anterior capsule is to clean the anterior subcapsular epithelium all around, 360 degrees, starting from the rim. And I've seen in all these cases that capsular contraction incidence is very low if you manage to clean most of the anterior subcapsular epithelial cells.
In this particular group. Otherwise, routinely doing a polish is not needed. But yes, in this subset of cases, and that's a great discussion. And Haripriya, please do stay on right till there. We want your input.